Welcome everyone. I'm Christian Yamini from Catholic Relief Services. I'm going to act today as the moderator of this session. We welcome all of you here present and those who will join us along the line. Thanks for the interest given to this session of the conference on ICT4D for malaria elimination. We also wish to recognize and welcome our 4 panel presenters who will share with us their knowledge and experiences related to the theme of this session, which is community-centered malaria control and elimination digital tools. They are Dr. Krishnal Ariel from Save the Children. I hope you can see him. I don't know whether you are able to see him on the video. Dr. Yuan Simpson from Johns Hopkins Center for Communication and Programs, and Dr. Yusuf Keta from Muzo, as well as Dr. Fatou Fall from MEDIC. Our speakers will take us around 3 topics, which are mainly case studies. The first is the use of user-centered design in the development applications for community workers and community health workers supervisors, and these will be delivered by both Dr. Yusuf Keta and Fatou Fall. The second topic will be Little Mosquito, Big Problem on Facebook, which will be delivered by Dr. Yuan Simpson. And the third will be the use of digital tools for surveillance of malaria in Nepal for elimination, which will be delivered by Dr. Krishna Ariel. Just to recall that each presentation is set for 8 minutes. Then the 3 presentations will be followed by a discussion panel, will be open to everyone. So just to remind you again that if you have any question, please post it in the chat box or use the question and answer function. After the presentation, the full 3 presentation, we will go into response to those questions. Having set the floor, I wish to call on Dr. Yusuf and Fatou Fall for their presentation. You are welcome, both of you. Mike, to you.
Thank you very much, Christian. Hello, everybody. I am Dr. Yusuf Keita. I'm Director of Innovation and Learning at Musso. It's a great pleasure and a great honor for me to attend this meeting as a panelist. The topics we are going to address today will be co-presented with my partner and colleague Fatou Fall, West Africa Program Head at MEDIC. We'll present that together. So as it was already announced by Christian, we are going to talk about the tools and take a little bit of time to discuss about a particular functionality and some of the outcome and results that we obtain through the use of that tool. Next slide, please. Okay, so the first point that we will discuss is to do with the background, with the history. Our organization, Musso, started in this program in 2008, but it's only in 2016 that we decided to use and leverage technology to accompany our implementation. In 2015, we had 75 community health workers. We use the data in order to improve the care and the decision-making process in terms of logistics. We did have some difficulties as we had to print some of the sheets and the data and the issue related to the protection of data and also in terms of management of data. We had to work with 4 data entry officers and then we decided to expand in later on from 75 to 175 community health workers, which meant we can no longer use printed support and we had to consider and use a new tool to help us with the implementation. Next slide. So, As an organization, it is very clear that we are not a specialist in terms of development such applications. Our objective was to leverage technology in order to support the implementation. But us, as organization, we were not experts and were not really able to get involved in doing that. This is what led us to establish a partnership, a technical partnership. But before that, we had to define a certain number of criteria. And in the criteria that we defined, we decided that it will have to be a dedicated tool, open source tool supported by an expert team, and we started a transparency assessment process. MEDIC is a NGO which was created in 2010. They are partners with over 60 partners across 23 countries. And my colleague Fatou will tell us more, but their tool is today used by over 40,000 community health workers. So that particular context is quite important, and the reasons why we decided to leverage and use technology to continue with our work. So I will continue with the presentation. So the Community Health Toolkits, also called CHT. It's an Android application, typical with a mobile phone. It's quite light in terms of volume, and we need to consider what the type of devices that can use that app. And it has to be related to the activity which is done. The main function is to collect data, which is the basic function, which enable the community health worker to work offline and connect once a week or once a day, once a month, and transfer the data to the server. But not it doesn't only do data collection, but it can also help in coordinating the activities on a daily basis, send the reminders of activities to follow up, and this is what we promote through that dedicated tool. And as my colleague Yusuf Keita said, this is an open source, and this is thanks to the support of the government and NGOs, who, rather than using applications which you have to pay, which means it's difficult to scale up, that means that all resources are available through the website. Next slide, please. Uh, Something else is to do with the design and how this application was designed. We need to involve the end users. We want to have it placed centered on the human. That takes into consideration from the onset all agents, all actors and stakeholders with and for the medical agencies with through interviews and focus groups and so on. And in an interactive way, this will be a way to improve the functionalities and make sure these are meeting their expectations and their requirements. I give the floor back to Yusuf now. So as Fatou said, the data collection and the transmission of data is a main function for this tool, but it is worth noting to this there are some other functionalities which are hidden ones. So our greatest wish is to assist all community health workers to carry out their daily activities. So from that particular slide, I will tell you about a particular function, which is a tool to assist in decision making that enable community health workers to take decisions, make decisions, and based on the example here, in order to carry out the TDR for malaria, we are able to guide community health workers to carry out that particular test, and we know that this is an important factor in order to have a quality result. So thanks to images and the text, this we are able to guide the community health workers to carry out that particular test. And what we had in relation to that rapid diagnostic test, it was difficult to wait 15 minutes before we could read the results. So after 5 minutes already, we could, we could read the result, but that could be a wrong result. So we have incorporated this into the app, and therefore community health workers have a way to wait long enough in order to have a reliable result. Another important functionality which I would like to share with you, it's to do with the different tasks. As you are aware, if a patient is treated for malaria, it's important that the community health worker can visit him, and that follow-up visit wasn't a regular thing. So to have a reminder to know who has to be followed up or else. So that particular functionality, task-based management, is a way to find out when or and who in order to help accompany the patients through their treatment in general, but also for the malaria treatment. Next slide, please. So now, beside the application, we will tell you about another functionality, a major one that we developed not at the beginning, but once the need appeared, which is related to universal coverage. That particular functionality gives the possibility to the community health worker to identify the household, the area of intervention, to see who had a visit, how many visits per household, and so on, and when was the last visit. So this was introduced further to an observation. Beforehand, community health workers would visit the patient at home, and this would be counted. And it was very well that to know that a community health worker had for 300, 400, 500 visits. But then when we had to find out to which household was visited, we realized there was not an equality about those visits and how it spread. So when we discussed that, we found out that the main reason for that was that they were not able to cope with keeping track of which household they had visited. This is why we decided to develop that particular functionality, which enabled them to know very well which household had been visited and which one hadn't been visited. And in order to support this function, we decided to carry out a little research, a short research, that for which the results will be presented by Fatou. It's important to note also that in order to develop that function, we worked really hard to place the human in the center, and the community health workers have been involved at every stages, from the beginning to the end of the process. And we carried out a test with a smaller group to collect the data or to collect the feedback in order to listen to the feedback they shared in order to make sure this was implemented in the right way. So you have another 2 or 3 minutes to sum up. So if you could go to the conclusion, that will be very helpful. Thank you. So if you could go to the conclusion now. So in order to conclude, we can say that using technological tools is very important to support and accompany community health workers in agents and in order to deliver the good quality care. It is very important to involve and engage with all the stakeholders so that they can take ownership of that. Thank you very much. Thank you very much, Dr. Yusuf Keita and Fatou Fall, and we will come back to that later on. But what we can note already is that this tool can be used at community level, and also we don't need the internet access to collect data, even though this sometimes does need an access to internet.
So good morning, everyone. I am Joanne Simpson I'm the program officer from Breakthrough Action Guyana of the Johns Hopkins Center for Communication Programs. And my talk this morning is about how Breakthrough Action Guyana uses Facebook as one tool to reach its audience in the remote mining regions of Guyana. So in Guyana, which is a South American country bordered by Venezuela and Brazil, malaria is endemic in the hinterland regions where gold mining is the major economic activity. Breakthrough Action Guyana is a social and behavior change project that is working to improve malaria outcomes in mining communities in 3 of the hinterland regions with the highest malaria burden. The project's largest intervention is the Little Mosquito Big Problem social and behavior change campaign that seeks to increase risk perception to malaria, prompt care seeking, treatment adherence, and ITN use. Results from a baseline survey conducted in the 3 regions found that 47% of miners said that they access social media at least once per week. And during our formative research, Facebook was identified as one of the most popular sites that was used. The project therefore launched the Little Mosquito Big Problem Facebook page. The intended primary audience for the page is miners and persons living and working in mining communities. And the secondary audience is family and friends of miners, healthcare workers, and influential persons in the mining community. Content on the page has included an 8-episode animated miniseries about a miner's first experience in a mining camp, and this was broadcasted on Facebook Live. We've also posted the animated music video of the campaign theme song and dramatic audio spots. The page also continuously features posts about malaria from a fictional miner. We also integrate pictorial and video testimonials from influential persons in the mining community, posts targeting the secondary audience, call to action for World Malaria Day and Malaria Day in the Americas, and posts about national celebrations and mining activities. We receive direct messages from our audience on topics such as where to get ITNs, where to seek testing for malaria, if the treatment for falciparum can be used for Vivax infection, if there's a vaccine for malaria, and advice on symptoms and protective measures. So this graph shows how reach of the page has been increasing over time. Increased reach follows monetary boosting of posts, and we've been learning over time which posts increase engagement. Likes to the page is also being maintained steadily over time. What we found that works to reach our target audience includes monetary boosting of posts and promoting the page, This increases reach to our target audience. Features from influencers like camp managers, malaria testers, and persons known in the mining communities resonates with our miners. Short videos with humor increases interaction with posts and having contextually relevant content to our target audience. The Facebook private messaging has allowed persons to interact directly and clarify doubts and seek information. So some of the challenges we've had to reach our target audience include the fact that there's poor and expensive internet connectivity in the mining communities. We therefore shifted to targeting our secondary audience that lives where internet connection is stronger. Secondly, miners consume specific content and have specific interests like sports and popular music. So we've diversified communication channels to include WhatsApp and flash drives with popular music and malaria messages. Since the Little Mosquito Big Problem page is a help page, it attracts health workers, education, and educators likely due to Facebook algorithms. So we've had to try different strategies to attract more miners to the page, like using well-known influential miners in the community. And the regions that we target are also sparsely populated. So there may be a threshold for the number of persons that the page attracts. But we continue to use this tool as one of the tools in our toolbox to ensure that we're reaching our target audience with malaria messages. Thank you.
Thank you very much, Dr. Simpson. You really usually use your time. What I can return as key message from your presentation is that the use of social media such as Facebook featuring influencers can be used as channel for social and behavioral change in malaria prevention and treatment. So thank you very much. We will now shift to the third presentation, and will be delivered by Dr. Krishna Arya from Nepal, titled Using Digital Tools for Surveillance of Malaria in Nepal for Elimination. Over to you, Doctor.
Thank you so much, Christian. As Christian introduced, this is Krishna Aryal from Nepal. I work for the National Malaria Elimination Program through Save the Children Nepal, and based at the government division that works for malaria program in the country. I will be talking about an information system that we have been using for tracking the malaria cases in the country, which is basically a national malaria reporting system, and that is called Malaria Disease Information System. Next, please. Next slide, please. Briefly, I'll be talking about the system, what it is about, and how this information are used. I'll be talking next, and what types of health facilities have been reporting to this system will be my next part where I'll be talking. And then finally, I'll be talking about syncing the data with the National Routine Information System. And finally, I'll be touching a little bit about use of this system for decision making and other activities. Next, please. Next slide, please. We all know that it's very important to have the malaria cases reported within 24 hours of diagnosis. That is very much essential for a quick response and to prevent transmission in an elimination setting. We know that, this also has to, include spatial information that helps decision making about how to target resources and interventions to the highest risk areas and populations. Ideal elimination systems, surveillance systems should facilitate reporting, access to the data, decision making at all levels of health system, that's local, district, and national level. Next slide, please. This information system is a web-based information system, which is a real-time malaria case reporting system. And once the a case is confirmed, the reporting is conducted by the corresponding health worker by using SMS, commonly used, and it can be done also by using the MDIS app, that's the information system app, if we have installed that in our device, for timely notification of the cases to the national system. The designated person of the respective geographical areas review the cases once they get notification and approve the entries in the system, and that will help trigger a response. Next slide, please. You can go on next until this is completed. So this basically describes the health facility, how the cases are reported. And once the notification is done within the 24 hours of detection of case, first stage is the verification by the concerned officer in the geographical area. And if it is the case, then case-based investigation is completed within 3 days of the notification. And if it is verified not to be a case, then that is closed. Next one, please. After completing the form, we enter the details of CVI form in the system, and then we do the data analysis. This just shows about how do we send information using SMS. I won't take much time in this. This is basically using number that is provided through this leaflet, which is in Nepali though, but basically it's targeted to the health workers. They have this information here, how to report these cases, and they use this SMS number to send SMS to the system by providing details of the cases in brief. For example, using the patient name, phone number, and contact number, as well as gender, age, etc. Next slide, please. This describes basically the same thing about how the cases are notified using the app. And once the app is installed, we can also send the details as in SMS by using simple messaging, using the app in this case. Next slide, please. Next one, please. This is once the information is received in the system. This is the MDIS dashboard, where we can see that provides a range of functions from approving notifications to using the information for response. Next, please. And once the SMS are received, it is seen as SMS notifications are sent through SMS. They are verified by the officers at the provincial and national level, and then it triggers the part further once it is approved. Next slide, please. The request to approve SMS, this is upon preliminary verification. The reported case can either be approved or rejected. While approving the case, the designated officer will enter any missing information that was not entered while reporting the case. Next slide, please. Approved messages also can be viewed upon approval by designated officers and followed by a detailed investigation of the case by a team from health facility and local level government. Next slide, please. Once the detailed case investigation form are available, if the cases are verified to be a real malaria case, those forms are filled by the local health workers team, and those forms are sent to the center where we use to enter the details of the cases, and then that is stored as the complete data set for in the system. Next slide, please. Next, please. And then we can generate reports as they are required, and then where from the information that has been stored in the system, and they can be viewed. We have different functions in the system which can be viewed by the central level team that can analyze the data and use that. Next, please. This is just an example of how the details of the cases are viewed in the system, and that can be used. Next slide, please. As viewed in the system. Next one, please. Next slide, please. This is the GIS view of the SMS report, like the black dots or the shaded areas report, the no malaria cases been reported from there. And this is a notification by facility type. Basically, what I wanted to highlight here is cases are not just notified from the public health facilities or the higher level health facilities. These are notified from small outlets, drug outlets, small non-residential clinics, small laboratories in the periphery. So all levels of health facilities, including the peripheral ones, also to report to the system using SMS or mobile app in this as available. Next slide, please. The linkage with the routine information system, that's the National Health Management Information System. Data can be synced between these two systems, but this can only be done by the health facility and the municipality, which are the data entry points for health management information system in our country. And the health facility can sync the data from the records, and then only records confirmed malaria cases are synced with HMIS, and then the system is followed to get the required attributes. And once the data is ready to be synced, the MDIS will ask for the HMIS name, and then they confirm the sync. Next slide, please. We use the information available from the MDIS to trigger the response basically on the reactive case detection and foci investigation activities. MDIS facilitates also the timely response to the cases, and any deviation from the National Malaria Surveillance Guidelines are recorded and appropriate corrective actions are taken. This is how it supports the national decision making and corrective actions and is helpful for the program. Thank you so much. Next slide, please. Thank you all for your patience listening. Over.
Thank you very much, Dr. Krishna. We understood that the MDIS is a web-based information system used to improve the real-time malaria case reporting, and that the system is also compatible with the HMIS system available in the country, and could also help to address the prompt or evaluate the prompt treatment of malaria, the level of prompt treatment of malaria, the special information, and promote agile malaria surveillance system. So thank you very much. I thank everyone and thank all the speakers for all this interesting presentation. We have some questions. The question session is open, and we have some questions from the attendee.
The first question is for Dr. Yusuf. Can you please explain in more detail the user-centered design methodology you use to develop the application?
You have the floor, Doctor. Thank you very much. It's a very good question. I will try to give you more details about how this can be used with the concept and the methodology used in order to design this tool. It's important to note that what we did in developing the application or particular functionality, we did a direct observation from the community health workers on the ground, on the field, with the implementation teams, the technical teams will accompany the community health workers on the ground, and through that direct observation, a certain number of issues are raised in order to have a better understanding of the topic. Then we have discussion groups and smaller groups in order to collect any specific requirements or needs. And then we offer them the functionalities. So we involve them in designing the functionalities. And once these have been identified, these are being developed. They said, yes, okay, that's good, that's not good, okay. And then, of course, they are also involved in how the design is decided. So all those choices are done in advance. And once we have all those data, those information, then the technicians will gather all the details in order to integrate it in the application and develop the relevant function. Then we develop a prototype, and we have a pilot project We listen to all the feedbacks in an interactive manner. We integrate them progressively, and that the pilot implementation time can last up to 4 weeks in order to have the final prototype, which will then be scaled up alongside with the agents, with the community health workers. So in a summary, these are the steps which have been followed in order to develop that tool. And to summarize, we use a key principle about the user experiment based on visibility, feedback, and the positive strengthening. Thank you.
Krishna, there are two other questions for you, the two next questions. The first question is the MDIS an open source application? And the second question is, how do you ensure that the MDIS is fully owned and managed by the National Malaria Control Program?
Thank you so much for the question. For the time being, this is not an open source application. This was particularly customized for the Nepal context and developed by the National Malaria Elimination Program to be used in Nepal. With regards to ensuring that this system is owned by the National Malaria Program, this program is basically handled by the National Malaria Elimination Program team based at the national level, and the provincial level team are also oriented, and the sub-national team are also oriented about the system. However, with regards to managing and the overall basically looking at the aspects of taking control of the data that is received there and managing the data entered into the system. This is managed by the national program team based at the central level for now. And but the information wise, how it is being entered and how one can use the MDIS app, that is all been that is all shared with the sub-national teams. But the overall management is done by the federal or the central level team that is housed within the government entity, and they manage the overall system. Thank you.
Thank you very much, Krishna. Okay, we have a follow-up question. The first is how to further improve the ability of community workers in providing high-quality malaria services with the support of digital tools. I wonder whether Dr. Krishna have any answer or any other speaker or any person that has any idea of this. How to further improve the ability of community workers in providing high quality malaria service with the support of digital tools.
I can add in the question on improving the care quality. Decision-making process is done by the community health workers on the ground, and to see the level of education from the different actors, community health workers, in order to address any kind of difficulties they are faced with in order to use the technology. And I believe Dr. Yusuf can add to that. Indeed, Fatou, I believe it's important. I mean, the question that was raised is, for me, I believe, a good question. But I believe it's important today, if we want to have quality data, is to not consider that aspect when we develop the app. In the general view, the end user's task is not to collect data. So if we were to develop applications purely and only based on data collection, this would be considered as a burden for the end users and would lead them not to collect the data in an appropriate way. So it is up to us that not to develop some functionalities that will enable those end users to do their work accordingly on a daily basis. So the design has to be done in such a way that the data collection aspect is hidden and highlight the functions that will help them in doing their work every day. So the agents, the community health workers don't want to be seen as data collectors. So if we have that concept in mind and that we apply it as we develop the application, I believe this is a better approach to obtain an even better data collection process and more efficient. Thank you very much to both of you, Dr. Yusuf and Fatou.
La seconde question ici sur le chat, c'est addressing any regional differences in digital malaria interventions. How can those tools be effective in other countries? I think this question will be best addressed to Dr. Krishna, because we know you have the MDS solution in Nepal. Do you think this can also be effective in other countries?
Sorry, can you repeat the question?
Yes, we are looking towards the regional differences in malaria, in digital malaria interventions. And we say the tools you presented today is being applicable in Nepal. And we wanted to know, we're wondering if this tool could be applicable to other countries around malaria countries around the world.
I'm sure this will be very much applicable to other countries as well, because this is a very simple system, web-based information system, and can be customized to other countries using local languages and so on. And the development part also is not so complicated. We can definitely share the how it is done and the know-how of the system, and I'm very much confident that this can be easily used in other countries of the region. Thank you.
Yeah, just a follow-up question from my side on this part. I wanted to know whether the HMS system used in Nepal is a DHS2, because you
yes, it is
between the two. Yeah.
Yes, it is DHIS2 based system. You're right.
Thank you very much. So the final question we have here is what community center tool has potential for the biggest impact on malaria control and elimination? I think this question will be to everyone that has any answer about that. Is there any community center tools that has the potential for biggest impact on malaria control and elimination? Is even open to everyone in the hall, even the attendees. Seems I think we have various tools. I think all tools are very important. That's my own perception. That all tools are very important. It's just to know the best tool applicable to the a very specific country context. As I was asking some time ago whether we are using DHS2 in Nepal, and I think those countries that are using DHS2 might depend on the context, whether they are in the pre-elimination, the elimination, the control, or phase of malaria, who choose the tool are acceptable and adaptable to their own context. Any other comment from the attendees?
So, Krishna, I think you responded to the question from Jocelyn in the chat on surveillance techniques, but I don't know if you wanted to expand on that.
Thank you so much, Susan. Basically, once the cases are notified, as I mentioned in my presentation, this has to be first approved or rejected by a designated surveillance medical coordinator. Once that is approved to be a case, the strength of this system is that we have a local level team that is comprised by the public sector health worker working in the local level health facilities, and a team of health workers complete case-based investigation, that is a detailed investigation of the notified case, which is malaria case, and that is the heart of the surveillance system, I would say. So completing that case-based investigation form is the key to our surveillance system, and that will pave the further course for our response. And that's very much crucial. And the further steps, such as completing in other responses, for example, active case detection and foci investigation, etc., are also continued by the same team of health workers at the local level health facility. So that's how the response goes after the cases are notified. Yes, thank you, Susan. I think that was what I had to say on that part. Over.
Thank you, Krishna. Any other questions, Susan, from the floor?
Yes.
Christian, I have actually answered the other question as well, because maybe I do not have much to elaborate on that, since we do not have such experience of using this system for malaria mortality. But as I have written there, this is a system that has been extended to the lowest level of the health facilities and the communities. I believe this can well be used for reporting case mortality as well. Thank you. Over.
Thanks, Dr. Krishnan. Any other question from the floor?
Yeah, there were two other questions for Dr. Joanne.
Yeah, we can take them. We still have about 6 minutes left.
Okay, great. So the first question came in French, but I'll translate it. Is why did you pick the choice of using social networks, knowing that the target audience is limited in using these kinds of communication tools? And the second question is, were internet or coverage and or access to mobile phone an issue for the minors? And if so, how did you deal with those issues and address them?
I think this question is addressed to Dr. Young.
Yes, thank you for those questions. So when we conducted a baseline survey before we implemented our interventions, so we conducted that survey with minors in the 3 target regions, and it showed that minors do use social media and they do have access to smartphones, and they use those. 47% of minors do access their phones and social media at least once per week. And that Facebook was a popular site that was used by minors. Yes, the internet connection, the internet connectivity is a challenge, but social media is still very popular in the region. So what we've done with regards to the internet connectivity issue is to try to target the secondary audience. So that would be the friends and family members of minors, healthcare workers, people that the minors would interact regularly with. So, and we post messages to target that secondary audience so that they are motivated to encourage minors to seek treatment, to complete their treatment. So we also work through our secondary audience, and they live in areas that might have stronger internet connection than the mining camps. But we do have mining camps that would have different mechanisms for internet connection. Thank you.
Thank you, Dr. Simpson. Last word from Dr. Krishna.
Une conclusion à partager. Merci.
Thank you, Christian. Maybe I'd like to mention that some tools that help health workers to have some information about response to the cases. If they have any doubts, they could ask in that application. So such kind of application, if it is developed and used even in developing countries, because nowadays internet connectivity is very good, and they could try, one could try to develop an application that is targeted to the health workers, so that can be used by health workers whenever they have doubt, or that can be used as a free flow information to the health workers. So that, I think, is one of the things we could think of. Thank you very much. Over.
Thank you very much, Dr. Krishna. Thank to all the presenters for sharing with us all these best practices. I think most of us will learn from those. I also wish to thank all the attendees for their active participation and contributions. Thanks to Suzanne, thanks to Sonja, and thanks to all those who are working behind the screen or the scene. I wish to say have a nice day to all of you. Thank you very much.